Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy that you chose to spend this afternoon with us. We are going to have a very timely discussion today about something that is very current and very serious. And without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
Thank you very much, Dr. Barbara Davis-Stevens. Thank you, Dr. Ivan Walks, Dr. Jocelyn Hind, and Dr. William Lawson, and of course, Simon. We do have an excellent speaker who's been with us many times in the past. In fact, I had to go way back in history and find her bio. So she's going to correct me if I make any mistakes. I'm just going to take a few excerpts because it will take me all afternoon to read her bio. Our speaker today is Dr. Virginia King. She is director of the Marion County Public Health Department. And it did say on here, associate professor. I'm sure now she's professor of medicine at Indiana University School of Medicine Infectious Disease Division. She is also the past president of the American Public Health Association, which is the nation's oldest and largest public health organization. She also has been chairman of the board of the National Medical Association. She's a past president of the National Medical Association. And I'm proud to say that she did some of her training at the University of Cincinnati, of which I'm a graduate myself in the College of Pharmacy. So she and I are sister and brother in there. She also has been a part of CDC, and she's been a part of the board of the CDC and health department that was determining what infectious diseases are important in the United States. And she was proudly, with everybody who knew what they were talking about, removed from that so they could put up Robert Kennedy's people. But I'd like to introduce you to speak today, Dr. Virginia Kane, NMA past president, my friend, and breakfast buyer. Dr. Virginia Kane, the floor is yours.
Well, thank you so much, and just so nice to see so many familiar faces, and we're having some historical challenges that we're seeing with respiratory virus.
You muted yourself, Dr. Kane. Dr. Kane, please unmute. Simon?
Okay, I got it now. Sorry. I think my computer is just, I believe I have ghosts in my place. They're just muting me like nobody's business. But I think we're seeing an unprecedented act historically in this country that we've never seen before, where as a result of removing a lot of my colleagues, infectious disease experts in the different fields and spectrum, to be replaced with a new committee. We're now recently just had this advisory committee under under our Secretary of Health and Human Services, Mr. Kennedy, remove what we call universal childhood immunization recommendations. That is so critical, and it does appear that there is no scientific evidence based on these removals or related to this. And so it's going to have huge implications for a lot of our patients, especially our pediatric populations and our patients who are immunized and considerably. So I'll start, if I can have the first slide. So right now, what we're seeing, and this is no surprise, a lot of times we start to see infectious disease cases start to occur around after Thanksgiving. And then it surges like in December and January. And so we've seen an overall high respiratory illness activities driven by influenza and RSV, but we've also seen a much lower activity with COVID-19, although we do have a new strain that's out there called XFG that we may find is way more contagious than the prior variant strains for COVID-19. So, and we see that our biggest activity is normally in late January as well as February. But as a result of the elevated influenza activity, and you're going to see elevated RSV activity that we're seeing in our children, we expect to see way more sick days, higher strains on our clinics and our hospitals. But of course, our young children, especially ages of 0 to 4, are going to be at the highest risk for having the greatest number of influenza cases as well as RSV. And we're already seeing nationally a number of pediatric influenza deaths as a result of the removal of universal immunizations against hepatitis A and hepatitis B. CDC is no longer saying you need to do universal immunizations against rotavirus, RSV, flu, and meningococcal disease. And so if I have my next slide. So let's talk about the high burden of influenza. Black children have had the highest pediatric influenza associated mortality rates. Right now on the slide, you can see how at 35.9, that we have the highest rate of hospitalization rates for Blacks, but they also have the highest mortality rates, showing a rate of about 5.8 deaths per million compared to others, at least 3 times the rates of our white counterparts, with our Alaska Native Americans having the second highest rate, followed by our Latino community, and then our white with the lowest rates for our Asian populations. And so you can see these higher hospitalization rates with flu are showing these studies, but younger children are the most affected. So are greatest among all the children under the age of 5. And the other issue that we have to understand is what's so important about these recommendations by the federal government is we have something called Vaccines for Children. And this is a free program for low-income individuals who can't who have lack of insurance or who can't afford to pay for the vaccines. And so this way they're provided free vaccines related to vaccines for children. And if they do have insurance, the insurance companies are obligated in order to provide the coverage for this. But if it's not a recommendation from the committee, then we may not have access to provide free vaccines for low-income families or families that meet the poverty rates. And they may be in conditions where they're overcrowded, a lot of people living together. They may be exposed on those frontline areas where there are higher risks for contracting infections. And so these are some of the burdens that we face. And I just want to highlight one other thing. One of the other recommendations also that he's removing universal immunizations for is meningococcal disease, meaning that now it's called shared decision making. You can have the vaccine, the parent can have the vaccine, but it has to be with shared decision making with their provider, and especially for high risk groups. And meningococcal disease rates are another one where we disproportionately noted it higher in Black, African American, and children. Although the rates are generally low in the United States, we still have higher risk for infants and adolescents and increased risk factors such as we see secondhand smoke and crowded living conditions. And so the rate for Black individuals for meningococcal infections is 1.5 compared to 1.1 that we see for whites in our older studies, which shows that we're significantly impacted by adults. But I think the recommendation that we're really concerned about is that we're no longer recommending universal hepatitis B vaccinations, especially for pregnant mothers, for their newborns. And so they're saying that they need to wait 4 months or later. And as we know, for a lot of our Black pregnant mothers, they don't always make it back for their postpartum follow-up. So we find that our rates are lower vaccinating pregnant mothers for hepatitis B during those first 4 months. And so that's critical, as well as the RSV burden. If I have the next slide. Now, I will say that for our COVID-19 activity, it's low. It is increasing nationally. And we are having some outbreaks of COVID-19 that are occurring in some school systems. And so one of the things that we have to be very concerned about is we're just a plane ride away from this new strain, which we're seeing significant COVID-19 activity in Europe and in London. And so one of the other things that we're finding out is our reporting of COVID-19 is not as great because we don't, we're dispensing out. People can now get their own kits from drugstores. And so if they have COVID-19, a lot of times it's underreported and we're not getting that activity. So one of the ways where we have replaced in terms of methodology for looking at our rates of COVID-19 cases are in those states that provide groundwater surveillance, where we're looking and sampling our sewage systems to see what our COVID-19 rates are in terms of determining how much activity that we have. Next slide. So RSV, which is elevated in many areas with ED visits and hospitalization increases among children ages 0 to 4. Almost in Indianapolis, almost 8% of our ER visits are RSV cases, and they're in the age group 0 to 4, followed with the next group, age group 5 to 17 years of age. And their rates are somewhere between 4 to 6% for RSV. And so, the recommendation is that you give the RSV vaccination as recommended for adults 75 years and for any adults 50 to 74 that may be at increased risk where they may have chronic conditions available to them. But it's more important about the infant. So a lot of times we'd like to have protection against maternal, that includes maternal RSV vaccinations during pregnancy, or we want to provide the infant antibody after birth. But still, one of the protections and things we can do the greatest is making sure that if you have a new baby or young baby in your household, be very concerned about what guests you allow into your homes if they have not been vaccinated, or can put at risk for your baby if that should occur. Next slide. Now, measles is probably the most incredible success stories that we've had in this country, where we eradicated measles in the year 2000. Okay. And as you can see here, in 2024, we started to see a major increase in measles, whereas before we were less than 50 cases back in, say, 20, just before the pandemic. And what has happened is because of this lack of recommendations for the measles vaccination, which we saw our first outbreak occur in a small town in Texas, and then in New Mexico, and some surrounding states now. And now we're over 31 some states that have had measles occur. And we're at 2,144 cases occurred in last year, and we're about to lose our status of being measles free. And this is one of the things that can occur secondarily to adults based on when they receive their measles vaccination coverage or they were exposed. But this is one of those conditions, and the pediatricians will know on this story that because it is so contagious, over 90% of people, if they're within 8 feet of anyone, over 90% of them will develop measles unless they've been properly vaccinated. So extremely contagious. So we always tell parents, travelers, if you think your child has measles, please definitely call ahead. Isolate them. Do not allow them to come into a doctor or a clinic's patient waiting room because it's so contagious and they can infect everybody in that waiting room area. Next slide. Whooping cough. We saw an outbreak of whooping cough in Louisiana, where I believe at that time we had the health commissioner, I believe, from Louisiana state that it was no longer important and they should not be promoting, told the local public health authorities it was no longer important to spend any money doing any advertising in order to protect or immunize for the whooping cough. And whereas within, I want to say, about 2 months of not doing their regular promotions of the whooping cough pertussis, we saw a huge outbreak in Louisiana that occurred. And so there was more than 26,000 cases of whooping cough in the United States in 2025. That has been huge. And so that's the main reason why it was on the rise. Whereas the year before, we'd only had 1,400 cases. So, and a lot, we do have to say, can be contributed to vaccine hesitancy, but also a lot of our pediatric cases where the immunity is waning. And so if you looked at the state of Florida, their cases of pertussis are at a 5-year high. They more than doubled their cases in 1 year from Florida. So they only had 715 cases in 2024 in Florida, but by the end of December the 6th, they had 1,454 cases. And most of those cases occurred in the greater Tampa Bay region. So it's just so critical that we have to address this misinformation related to vaccines. And unfortunately, we've seen a few deaths related to the whooping cough and what we can do about it, because there's really nothing we can treat the cost. We don't have the medications to treat it. And unfortunately, these babies and children, they're coughing for months. It's so disturbing. They're unable to attend school. And we've even seen some children, because the coughing has been so severe, fracturing their ribs. And of course, we get pneumonia behind it. So prevention is really critical, but very difficult when you have your health commissioners say that this vaccine is ineffective and doesn't recommend it for parents. So very difficult for parents to decide, what should they do. And so I will say that. Okay, next slide. So we're seeing a quiet surge again with tuberculosis. Part of that surge is related to we're seeing a significant number of immigrants that have been coming into our country in the last 5 years. And so that tuberculosis, even though a lot of them come through our refugee program, we still continue to have some individuals who are undocumented who make it into this country. And so we've been seeing a steady increase with tuberculosis, up 8% since 2023. Blacks make a significant number of cases, much higher than their white counterparts, at a rate of nearly almost 5 compared to 0.4 for whites. But we find that our greatest number of cases, at least what we're seeing here in Marion County and other places, that usually over 50% of the cases are in cases of people who are not citizens of the United States or were born citizens of the United States, that they came from outside countries. And we never want to forget that, someone's got persistent cough, fever, night sweats, weight loss. We really have to always test them for TB, or especially and treat latent tuberculosis, which they have a short period of time from their latent TB to develop tuberculosis. Now, it may not be a surprise that during the pandemic, we saw a significant increase in our sexually transmitted infections, with more than 2.2 million reported cases of chlamydia, gonorrhea, and syphilis. But whereas we saw and it made substantial gains in congenital syphilis over 10 years ago, it's making a comeback nationally. And we had almost nearly 4,000 cases in 2024, up for the 12th year in a row. And so it's a huge burden because we've seen like antibiotic shortage with penicillin during periods of this time, but also because of lack of public health infrastructure, we will treat the pregnant mothers with antibiotics, and they will get reinfected before the baby is born. And so we have to do increased testing, like in the first and third trimester and just at the time of delivery, in order to prevent congenital syphilis if we're able to treat them with antibiotics, penicillin, in time before the delivery. And so we just continue to have the resources and the services to get free access for sexually transmitted infections out in our communities. Next slide. Monkeypox is something we probably still should keep on the radar. We continue to see cases of monkeypox. There were 4,500 new clinical cases in 2023. We're still continuing to see those cases. It can spread very easily in healthcare facilities. And there's a rash that's associated with this condition now called mpox, and where there's a vaccination in order to prevent this. And so I'm sorry, I meant that I apologize. I was talking about the drug-resistant fungus Candida aureus that had 4,500 cases. But for monkeypox, we are continuing to see increased cases occurring among people who are unvaccinated or have only just received a one dose. We now recommend 2 doses for maximum protection, and gives protection over 95% of the time. But a new scare that's out there is a rare fungal pathogen that's been around for about the last 10, 15, 20 years, but is significantly in climbing and increasing, where it is drug resistant to most of the antifungal medications that we have. We're very concerned about this, and we're trying to jump on it and make the diagnosis, because it can cause huge outbreaks in healthcare facilities, and people who are immunocompromised are very vulnerable. Cancer patients, burn patients, so that it's so important that we have a infectious disease surveillance program in place in order to capture this particular drug-resistant fungus, because it can play major havocs in our healthcare systems. Next slide. So just to say why the impact's greater in Black communities, frontline, essential work exposure is the common driver, but we've seen also access to healthcare is critical, and poverty can play a role in that. As a result of the poverty, we may have transportation issues, insurance issues. You know, if you're working at a plant or something like that, it's very difficult to get time off. We also have a higher burden of chronic disease, which makes us, our immunity puts us at a higher risk for the flu, TB, and some of these other conditions. And a lot has to do with our environmental exposures. So it is true that for us to have our greatest impact, we have to figure out a way how to provide our resources to where people live, where they reside, where they are in their own social networks, where we don't have to force them to always come to us as healthcare providers, but are we in those communities where they can easily access to us? And do they have the resources where are they able to be able to get these resources free if they don't have the financial background or status in order to help this? So we're looking to see more mobile home testing, where mobile units are going into the neighborhoods, or they can set up in the individual churches, parking lots, barber shops, be able to have flexible hours, evening hours, weekend hours, even maybe to provide resources in school systems, public housing. But we always have to remember the number one thing is that most patients feel we are the trusted messenger. They look to us to provide them expertise and information and to counter misinformation. And that is something that we got to constantly, quickly do. Next slide. So we have to continue to provide through social media, education to our patients, that we really need to stay up to date with our recommended immunizations. We have to continue to practice and encourage hand washing, cleaning surfaces. But a lot of people don't take into the context how important it is to also have clean air, ventilation in the places where they live or reside. And it's hard. We tell people when they're sick, please stay home and away from others. But some people are concerned about losing their jobs. And so a lot of times they'll go to work even when they are sick. But we want to encourage people to wear masks in crowded indoor spaces. Someone's coughing or sneezing near you, try to see if you can create a distance between them. Try not to go to gatherings where it's heavily populated, where you may see and be exposed to a lot of high-risk people with extra layers. And then continue to fight to get the information out for everyone. But we have to do it in a way, let's see. I think that was my next slide. I think that was, we have to continue to do it in a way where we can give the message in the message where they can understand. Okay. And we have to address it quickly. So I'll stop there and I want to just make a few comments, but without the slides so I can see everybody. Okay. So
Thank you so much, Dr. Kane.
yes, before I start the questions though, one of our biggest problems, I think sometimes as providers, that we try to give the message in medical terminologies where the patient doesn't quite understand it. Our other biggest problem we have is an economic issue. And the economic issue is that the reimbursements for giving someone immunizations is a low reimbursement compared to, say, I'm seeing you for hypertension, I'm seeing you for diabetes control. So that reimbursement might be about $25 versus I can get $125 for the same amount of time if I'm checking your blood pressure or checking your blood sugar or other chronic conditions. And so, especially for providers who are out in private practice, where you're not part of a group, okay, you have to see so many patients in a day, what we call this RVU, 15 minutes, so many patients in order to break even or make it break even. So immunizations is a difficult subject, and you can't always explain it to a parent in 15 minutes to the level that they trust and they understand the information and feel comfortable that they have all their questions answered. So it could literally take you 45 minutes for the visit, and even that might not be enough. So those are some of the critical issues that we have to face, and we have to figure out how can we partner with our health departments or other entities to do that social media marketing and education out there, so less time may be required from the provider. But the number one person they say they listen to, if anybody, is their own provider. Okay, I'll stop there. Sorry.
Thank you, Dr. Kane. That was absolutely beautiful talk. I learned a lot. And let me ask you a question as the past president of the American Public Health Association. I'm a military fan. Dr. Ross probably didn't know that. But I read an account of what the United States military did in their raid to bring the president of Venezuela back to the United States. And they put a huge amount of military hardware in the Caribbean. They cut off the communications and the radar so our own soldiers wouldn't get hurt. They killed over 300 Cuban guards that would normally protect the president of Venezuela. And they took the president of Venezuela and his wife out of their bedroom and brought him back to the United States with all this preparation. So if we have that level of preparation by the United States government, what does it say from a public health standpoint when a particular population has twice or three times as high a disease rate or infection rate, and we haven't planned on taking care of them or let these infections run wild? I'm not asking you to be political, but from a public health standpoint, what's going on?
Well, and from a public health standpoint, I think we as a nation and a community needs to look at what we consider our values and what we consider our priorities. But I will also say I think one of the big issues that has happened across the country is something called affordability. And so if we don't have this infrastructure in place where we're doing the immunizations, doing the prevention related to this, guess what's going to happen? You're going to see these patients coming in large numbers, crossing our emergency room clinics, filling up our hospitals, maybe utilizing our respirators at a significant cost. So prevention saves dollars. You know, one shot saves on the average about $7.75 related to prevention. Let's talk about pneumococcal vaccine. You know, pneumococcus is the number one cause of bacterial pneumonia in this country. In this country. Now, it might cost actually a little over 200 some dollars, but compared to if I can prevent you from getting, and it's 98% effective. Look at the hospitalizations I am preventing, and just even step across the hospital and be hospitalized for one day, it's over $1,000. But with one shot for just one condition, especially with all the chronic health conditions, I'm saving an enormous tons of dollars from an economic standpoint, of affordability standpoint. But like I say, we have got to also do a better job of laying our case for the average citizen to understand where we're going with this, how this saves and protect lives. If I showed them a slide of measles, do you know we were experiencing 500 to 600,000 cases of measles a year up to the year before we got a vaccine for measles. 500 to 600,000 cases of measles a year with a significant number of deaths. Do you know that once we implemented the vaccine um, program campaign, we have, we got down to less than 1,000 cases a year. We got down to less than 500 cases a year. That just didn't happen by itself overnight. It happened because of the strength of the immunization and a wonderful job that we've done with that.
No, thank you. Dr. Barbara Davis Stevens?
Thank you, Dr. Kane. Um, Dr. Gibson and I actually were on the same wavelength. I have been wondering what we are going to do for reliable sources of information, both for medical professionals as well as for the public. Because the public needs to be able to access information even if they can't get to a provider. But that information needs to be reliable.
So that's a tough question, but there are over 50 organizations, including the National Medical Association, even American Medical Association, Infectious Disease Society of America. This is our national organization for infectious diseases that represents us in the United States as well as globally, working on a new database in a location that the public can utilize that will replace the CDC's database. We're pretty close. We're getting close now. And where that's going to reside, we still haven't quite finalized that. But here's something about that coming out shortly, I believe, in the next 3 to 6 months. But until that time, we have to use our own association to put out these recommendations. We push the American Academy of Pediatrics, what their recommendations are, the American College of Obstetrics and Gynecology, the American Academy of Family Practice. We have to, all of us are pushing these practices where we have based on evidence-based studies, where we make the recommendations and we're trying to follow just those standard guidelines. Now, here's the problem. I do need to say this. Um, if you're on federal funds for vaccines for children, like for where I am in Marion County, I cannot use those vaccines in a different manner than how the federal government is telling me how to use it. So that means I have to buy through general funds, general property tax funds, additional vaccines in order to meet the standard recommendations from our leading medical organizations. So that I'm not in violation of the federal law, but I'm providing the highest standard. But I only have a limited amount of money of vaccines I can buy for I've got 1.8 million people here. So it's very difficult for me to have that vaccine for everybody, but I have it for all the children who require the vaccinations and adults, but it's difficult. And this is a commitment that's been made by almost one part of the Big Cities Coalition. So the 35 largest health departments, health cities, are making this commitment in terms of trying to still meet the need and the resources, but it's difficult. Okay, I'm sorry, Barbara. Yes.
No, no problem. Excuse me. I wanted to add a follow-up to that question, which is we've already seen this year where there was an unfortunate mismatch on the strain of influenza A that wound up being the predominant strain. Now, and given all of the dismantling activity that has been going on, who or what is going to pick up the ball to make sure that our vaccines are matched? You mentioned at the beginning, we've got a new variant of COVID, which, we know
Right.
we're going to have, and we'll have new variants of all of, it's not an unknown thing. But what's of concern is what entity is now going to take the ball and make sure that our vaccines are effective.
So, Barbara, I hate to say that's an excellent question. And honestly, we don't know the answer to that, to be honest. Now, we do a lot of work and we work still with World Health Organization. We work with our colleagues in the other Southern Hemisphere who have their respiratory viruses occur like a couple of months away before we do. And we will still have our academic medical institutions who are doing research that will try to tell us what the strains are occurring, what are we seeing. Like this new strain is in about 68% of the influenza A strains that we're seeing now for influenza A and B, and we're seeing more influenza A strains than any other strain. But the problem comes, who makes the decision, like you said, with the companies what vaccine to produce based on the particular strain. And so, one of the other things that we're trying to do is in those 50 organizations, we're also trying to work with the manufacturing companies that produce these vaccines in order to help maybe address that. But the recommendations traditionally have come from the ACIP group, who, as you know, have a number of their members who are anti-vaccine or anti-vaccine critics.
Dr.
So
Walt,
I really don't know the final answer how that's going to play out.
Okay.
Dr. Ivan Walks.
Thank you, Dr. Maxey. Dr. Kane, once again, you're going to mess with my sleep because it's very hard to get a restful night's sleep when all of this is going on because it's just, as I often say, it makes me sad. As a country, our unwillingness to care for each other makes me sad. As a county health official, when you are working, can you talk about just how important it is for us, in addition to us commenting on what the federal government is doing, how important it is for us to be engaged in our local leadership, our local electors, because somebody locally is saying you can spend those local property tax dollars to get some additional stuff. So can you talk a little bit about how, as a locally, as a person who is dependent on the local elections and on people getting involved in their community, how important that is for the work you do?
And Ivan, you highlight a major point. As healthcare providers, the communities, they need to look to us for leadership. Who, if we're not providing it, who else can they look to? And so we need to meet with our policymakers, our city council members, our state legislators. Um, we need to have town hall meetings, where we can have our town hall meetings sponsored by our clergy. We can have town hall meetings sponsored by our neighborhood associations in our communities. And we have a number of organizations, our fraternities, our, Divine Nine or whatever, but we have got to get the message out. And that means we have to take time away from our busy schedule as providers to make the time to do this because it impacts all of us adversely, negatively. Now, this past week, I was at our state house, and in Indiana, it's predominantly Republican, okay? And they have the ability to make decisions and not impacted by our Democrats, all right? But I want you to know I'm so proud of our state legislators because we didn't undergo the redistricting that would have impacted the local people's voice, what they wanted, what their concerns were. And I say this because I was talking about safe syringe programs. Because Indianapolis had a hepatitis outbreak with over 1,000 hepatitis C cases back
Wow.
in 2018, over 1,000 some cases. So we implemented a safe syringe program and it was up for renewal. And if it doesn't get renewed this year, then every safe syringe program in the state of Indiana will have to be discontinued. But I was impressed when we provide the evidence, we provide the information, people ask the questions, that a significant number of my Republican policymakers said, we're going to pass this. This is important. And it was sponsored by a Republican legislator. And 10 out of 2, that's not unheard of. But no surprise that we had our Indiana state prosecutors across the state say this is a terrible idea, anecdotally. We're having all these syringes all over the place. People can accidentally hurt themselves. Our law enforcement people are at risk. Well, guess what? We did a study, academic study, and showed that with this program, we were reducing accidental sticks by 66% to our lawmakers. But look to see what can happen when someone is basing things on their perception, but it may not be reality. So we also have to find the resources to do the studies, the evaluations, scientific evidences, be involved, but get that out there. And that made a huge difference.
Thank you. Is Dr. Lawson on?
Yes,
Dr.
Dr.
Lawson is
Lawson, I know
on.
he asked a
Yes,
question
I
over
am.
here in the chat. Dr.
Hello,
Lawson,
Dr.
ask the
Lawson.
question again.
Yeah. Again, just want to note, as I've said before, that one problem is we have a triphasic world. We have physical health, mental health, and substance abuse. Folks do not talk to each other. Trusted advisors for men in mental health areas and substance abuse. Folks very educated, very well known about different kinds of their area, know almost nothing about infectious disease. And not only that, do not usually share that information with their patients and others. And I'm just wondering, can we do something to do about that to get, especially mental health and substance abuse, in which all the disorders that you've described have higher morbidity and mortality?
So let me just say that mental health is, I know in our community, we did a community health assessment, is a number one issue in our community, hands down, of all our priorities, number one. And you know, when people have a mental health issue, they self-medicate themselves, because they want to feel better. Okay? They want to feel good. So that's how a lot of times how we have our substance abuse problem. But you're right, Dr. Lawson. We don't always in our mental health facilities do a screening where they're screened for HIV. They are screened for a substance use disorder um, in a mental health clinic. I don't know how many are screened from an infectious disease standpoint, but we're probably a little bit different compared to most people because we had the largest HIV um, substance abuse outbreak compared to anyone in the country. So I think we do a much better job of screening for HIV, um, hepatitis C, um, and we're really trying to push, and we're making a difference, pushing Narcan out there, doing education in our communities, in our neighborhoods. But like you said, we don't always have that connection between the infectious diseases and mental health. Because, we got to realize syphilis, if you let it go long and it's undiagnosed, people don't realize that that mental health may have an infectious disease cause. It's not related to drugs. And so we've seen that happen in a number of cases locally here.
And thank you. Dr. Neighbor Stevens, is there anything in the chat we need to deal with at the top of the hour?
Dr.
Dr.
Sherrod
Sherrod
has
has been.
her
Dr. Rod
hand
has
up.
her hand up.
Okay.
Jesse, you're on mute.
Okay. Yeah, thank you, Dr. Kane, for sharing all this important information with us. And my compassion goes out to you being out there in it. I know it's a real challenge. And my question is concerning the lack of recommendation now of the hepatitis B vaccine. And I wonder if you can talk a little bit about that and your opinion about the effects of not giving that vaccine at birth now.
So you know what happens with hepatitis B. If you have
It,
oh, can you hear me?
yeah, I can hear you.
Yes. So you know what happens when you have hepatitis B. A significant percentage go on to become chronic carriers of hepatitis B. And as a result of the chronic carriers of hepatitis B, they develop cirrhosis of the liver. And that cirrhosis of the liver, an annual cost is going to be somewhere between $300,000 and $400,000 a year, just the cost of taking care of someone for cirrhosis in a year. But then you have the small 10 to 14% who go on to develop liver cancer as a result of the hepatitis B. And so, chronic carriers of hepatitis B, they're going to be sick, and treating them. Some of them develop from their cirrhosis, ascites, and at high risk for secondary infections. So these are life-threatening conditions that we're setting up for our pregnant mothers. And this is a mechanism when our babies are not protected and immunized from hepatitis B because they don't want you to immunize any of these babies with hepatitis B in the first month of their life. So they're saying, no, we don't want you to do this immunization in this first month. So really trying to avoid that. But it's going to have huge implications for us.
I have one other question. Do you think, I mean, is it possible to test the mother at the time of delivery and determine whether she's positive or not, and then immunize the child? Is that a recommendation or an option
Yes, so no doubt about it. You can definitely test. They'll definitely test the mother to see if the mother's got hepatitis B.
Thank you very much. I want to see if I can get next year. The NMA is going to be in Puerto Rico. Is Dr. Harford on the line? Is Dr. Harford on the line?
Yes,
Someone.
I am. Hi, Dr. Maxey.
Hi. Do you have a comment or question for our wonderful speaker today? I know
Yeah.
you run a big healthcare facility in Puerto Rico, and you're faced with some of these chronic diseases.
I'd like to say, first of all, thank you for inviting me. And Dr. Kane, this has been very enlightening, just not from a policy perspective, but when you have brought a number of challenges when we look at policy integrated with cost. One of the things I've shared with Dr. Maxey often is that how can we look at the policies and what everyone is doing, specifically you currently, and how we manage vaccination in the community when there's a lot of precedence already from a policy perspective in terms of how the ESRD population is being managed. For example, we are mandated and tracked and penalized if we dialysis units do not meet the benchmarks of vaccination numbers. We saw this with COVID. We have to vaccinate for the flu. We are required to, on an annual basis, to screen for hepatitis and vaccinate and give you the immunization. So there is precedence, and how can we use that existing data that we have nationally already, where African American, our Black population is disproportionately affected by renal disease? There's got to be a way that we can look at the data that's out there and then expand that data to other communities of color, our Hispanic communities, our Asian Pacific Island communities, and even look at how this is impacted in the rural communities and the U.S. territories. So, Dr. Maxey, and we've done quite a bit of work in the U.S. territories, and there's a lot of differentials in community application to vaccines. So I would say that listening to what you have talked about and the other guests have talked about, I think it's worth a challenge to really evaluate how does vaccination, the role of the ESRD vaccination program, how can we use that to strengthen what we need to do from a national perspective in reaching out to our communities?
Thank
And there's
you.
a lot of heavy regulation.
Yes. So I do know that we're trying to look at more communication strategies. What may work for a young Black male in his 20s is totally different for a Black female over the age of 50. And so
Hmm.
different strategies based on race, sex, gender, and their attitudes, and what should that look like? And what will they respond to? So a lot of Black males, when I told them they needed to get a COVID-19 vaccine, oh, I'm healthy. I go to the gym every day. I've never gotten sick. So why should I take a COVID-19 vaccine? And I tell them, hey, it's not about you. Okay, to be honest, I don't care about you. It's about your mother in your house who's got heart disease and your father's got prostate cancer that I'm worried about. And you have the ability to kill them if you bring in a COVID-19 infection. And you can have no symptoms and be unaware of it. So it's not about you. I mean, if you want to put yourself at risk, that's your problem. But I want you to be concerned about your grandmother and your parents. And if you look at it from that perspective, then we think about whether you need to get the COVID-19 vaccine. So I think different messages resonate differently with different people, what they consider is important for them.
Dr. Kane, we appreciate you so much.
Thank you.
As we hit the top of the hour, you care to have final comments for today?
Let me just say that the NMA is putting out a position statement in regard to Dr. Brandy Freeman, as you know, who's our president-elect, and she's a pediatrician at University of Colorado's medical school and works very closely with the American Academy of Pediatrics. We're going to also put out a new revised guide for immunizations for our providers and for our patients to look at in terms of what they should do in based on some of these recommendations. And we hope to get that out within the next 30 days. Our position statement will be out, I think, this week, but our guide may take us up to 30 days to get that out.
And thank you so much. Really appreciate you being on with us today. Dr. Lawson, final comments?
I just wanted to make can you hear me?
Yes.
Good. I just want to make the point that people who are mentally ill get influenza, people who are mentally ill get COVID, people get all of these disorders. Those who have an opportunity to interact with these folks, make sure they get the word out to take uh, the appropriate preventive options. It's all too often, those kinds of issues override concerns in terms of public safety and healthcare.
Thank you,
Thank
Dr. I'd like to get a pair of suspenders like that. Dr.
Okay.
Ivan Walks, final comments?
Thank you, Dr. Maxey. Yeah, Dr. Lawson is always, ragging it up, sharp. So let me say a couple of things, Dr. Maxey. One of them is Dr. Maxey will often ask me what row I sat on in church. Well, I was in church today, and I was wearing my mask because it's January and February is coming, and people are getting sick, and it's important for us to model the behavior that we ask other people to do. When I'm sitting in a room with a few hundred people and everybody's singing and worshiping, that's a wonderful thing. And I have on my mask, and I went up to another woman that had a mask on, and I complimented her on wearing her mask. And neither one of us is sick, but we're not trying to get sick. So I just would encourage us to be willing to talk to people and encourage people who are following Dr. Kane's advice about that kind of behavior that can keep us all a little bit safer. Other thing is, I don't know how much we noticed over the last few days. There's been some movement within the government about people being willing to stand up and say, you know what, we do need to have a vote on those Obamacare subsidies. You know what, we do need to have this and we do need to have that. And I think we should, one, pay attention to what's happening nationally that may begin to shift this ridiculous tide that is going to continue to keep us, as Reverend Jesse Jackson said, getting to be the sickest and dying the quickest. There are some positive signs as people are beginning to push back at the national level, little ones, but I want us to pay attention to those, to talk about those and encourage people to stand up and ask the questions like Dr. Maxey asked at the very beginning. If y'all can drop all this money to go pick up a guy out of his bed, can we spend a little bit of money to give Dr. Kane the immunizations that she needs to protect our community? I think those are reasonable things for us to ask. I appreciate Dr. Maxey's courage. People don't talk enough about the importance of courageous leadership, but I want to talk a little bit. I'm done now, Dr. Maxey. I talk too much, but courageous leadership makes a difference. Dr. Kane is willing to travel, willing to come on Black Health Trust, willing to highlight the things that are important in our community. And that kind of leadership matters a lot. Thank you, Dr. Kane. Always good to see you, my sister. Thank you, Dr. Maxey.
Dr. Walton give us a Spring-On medal. Dr. Barbara Davis Stevens.
Oh, again, thank you, Dr. Kane, for helping to enlighten us all and giving us the information weapons that we need to carry on what we need to do. Again, I want to urge everyone who listens to our broadcast that you are part of the strategy. You have a voice and you have a vote. Please, please get to work.
And thank you so much. And for my final comment, I went to church myself this morning, Dr. Walks. I sat on the
Of
second,
course.
and the sermon was by Bishop Kenneth Ulmer, and he spoke on the 23rd Psalm. The Lord is my shepherd. I shall not want. He gave one of the most cogent addresses I've ever heard on what turns out not to be so simple of a psalm. And I encourage people to go to your Bibles and your expositories and commentaries on it, and read, I shall not want. The Lord is my shepherd. And that's my comment for today. Thank you, everybody. Thank you, Simon. Thank you, everybody, for being with us today. Have a great Sunday. Waiting on Bad Bunny in the Super Bowl.
Bye.
So, bye.
Good
Thank
day,
you, Dr.
everyone.
King.
Okay, thank you.